And I can also see Hillary. Hi, Dr. Ari.
Hi, Tim. How are you, Weston?
Hi. A long time.
Long time. I'm on quarantine.
Hello, Dan. We are live.
Okay. All right, fine. So I think Dr. Khalid is joining us shortly. He was just asking for the link. So I'll not go through my Twitter. So let me just get this.
Yes.
All right. So we start off.
Yes.
We are good to start. I think we'll give Dr. Khalid time to when he joins us. Well, then we'll be able to notice and welcome him. I think. Others, good afternoon, ladies and gentlemen. Thanks a lot for joining us on this short discussion that we'll have, which will be running from 2 to 3 p.m. Hopefully we'll be having adequate time for that, for intensive discussion. This is one of the events that we are having as we say we'll be celebrating International Day to End Obstetric Fistula, which will be marked tomorrow, 23rd May. It is a Saturday, and therefore we've taken advantage of today, the Friday, to have this activity. So this year's event is just amongst the other few, though it's a rare one to have it virtually because we are taking advantage of the technology. Many of us know the pandemic that we do have, the COVID-19, which has made us to change to a new normal of using the virtual system of doing things, social distancing. Okay, let me use the word physical distancing, but socially we are connected so that we don't find Habiba, who is locked down in Malindi, feel like she's socially desegregated. Nevertheless, we are here, and thanks a lot. This year's theme is End Gender Inequality, End Health Inequities, and we do have to end fistula now. I think this is a running theme as we look towards the 2030 when we say ending fistula, obstetric fistula within our generation as far as the Vision 2030 for the SDGs are concerned. By and large, we know that obstetric fistula is a great challenge for us and in our country, and so it is in many developing countries. So it is known that over 2 million women and girls live with fistula. This number changes between 2 to 0.5, and it means that as we try to mop the team who are here with us, together with others across the globe, try to work out in terms of prevention, but this number seems not to be going down. And indeed, in some setups, possibly even ours, the actual number is not known. So these are worked on estimates based on models. So we will be discussing this important topic, and we have a team of experts here, various programs, and some of them have been my teachers, and they have trained me, at least even for me, let me talk for myself. And the UNFPA, in collaboration with the Ministry of Health, welcomes each one of us to participate in this event. We'll use the lens of the COVID-19 pandemic when we know that this disease has ravaged and has strained the health system. And many a times also because of the measures which have been put in place, many of our women are not accessing skilled care, particularly the skilled birth attendants. And therefore, many of them are prone to getting, even acquiring more fistula cases due to the obstructed labor. And even worse still is the ruptured uterus and bladder among many others, if not just the fatality, which is in the worst scenario that we fear. So as we work towards the ending maternal deaths, we're also working towards the zero obstetric fistula in this generation. So in the morning, we had between 11 and 12, we had a country representative moderating a session on Twitter chat, and some of the panelists are here with us, and it has been quite intensive, and we thank you for your participation. So this session will have more of the presentation, which could be formed slides, and also form of just general discussions on the issues of fistula, which is saying is a hidden tragedy that we must end it even despite the COVID-19 pandemic. So on behalf of country representative, Dr. Demolo Lute, let me welcome each one of you to participate in this. And many of those who are following us on Twitter and Facebook can make their remarks, can make their statements, will ask questions to the panelists, whom I'm going to introduce shortly. And we'll also be joined, I don't know whether he has joined us, Dr. Kaliti Stephen, who is the head of Division Reproductive and Maternal Health. Is also going to be with us here. And then we also have Dr. Hilary Mabea, who is a renowned fistula surgeon at Gynocare Fistula Hospital in Eldoret. Dr. Weston Kisa, who is also a renowned fistula surgeon, Kenyatta National Hospital. We have Habiba Mohammed, who is the coordinator with the Fistula Foundation, based in Mumias, or in Western Kenya, but currently, because of the COVID issues, while on duty, she's locked in coastal region. Karibu sana. And we also have a program director, AMREF, the health charge of health systems, Dr. Elizabeth Wala, also renowned advocate for national health or health system strengthening, and we'll be able to discuss with us here. And more important also, we also have a fistula survivor who will also give her story. Is currently helping other fistula patients in a fistula hospital at Gynocare. Incidentally, in her surgery, that surgery was supported by UNFPA many years ago. I don't think even I'd joined UNFPA at that particular time. So let me confirm whether Dr. Kaliti has joined us. I don't see Mukiza. Dr. Kaliti, I'm not seeing him, but anyway, I think we'll start off and sorry? So we'll start off and we'll allow him to give his remarks a little later. He comes because he was just asking me for the link which I'd already sent. So we I believe probably is trying to connect with us. I'm going to put up my presentation, which is a short one, just giving highlights. Okay. All right. My name is Dr. Dan Okoro from UNFPA, working in the Kenya country office. So I'm making this presentation on behalf of the UNFPA office. And just to introduce UNFPA and what we stand for as United Nations Population Fund, which is an agency responsible for delivering a world where every pregnancy is wanted and every childbirth is safe and every young person's potential is fulfilled. And all this is actually in line with the prevention and management of obstetric fistula, that's the topic of our discussion today. As I had mentioned, International Day to End Obstetric Fistula, the theme for this year is end gender inequality and ending health inequities. All this will contribute to the ending fistula within this generation. So much of this discussion has also taken place indeed during the Twitter chat, and which was moderated by our country representative, Dr. Demola. And we're also going to have more discussions on this year. And we still see this quite relevant in our current generation. In being the lead and one of the founders of the campaign to end obstetric fistula, UNFPA stands to provide this strategic vision, and in this case, also getting into having this being declared within the United Nations Assembly, and then talking about technical guidance and support, providing medical supplies and equipment. And we did this even for our Kenya country office. We supported the equipping of some of the facilities about 6 years ago, and training and capacity building for the teams, the fistula teams. And also we currently work on a continuous basis on fistula prevention, its treatment, and also some work on social reintegration, as well as looking at it in strengthening the sexual reproductive health and emergency obstetric services, which are relevant to this. And as you did mention, our global strategic vision is to end unmet need for family planning, because when we do end this unmet need for family planning, we also contribute greatly, immensely to the prevention of fistula and ending preventable maternal deaths, because we do know that for every maternal death is about 20 to 30 women who suffer the devastating obstetric complications. So when we aim to end that maternal death, then we also to prevent the fistula itself. And gender-based violence, many of these women who suffer fistula, we do know that they have is because of the gender inequalities that I've mentioned, as well as also the inequities in access because of the cultural or harmful practices which hinder the access to the services. And many of us do remember the ICPD, the Nairobi Summit on ICPD 25, yes, which was co-hosted by the Kenya government, United Nations Population Fund, and the government of Denmark. And it made commitments, and some of which I've already mentioned there. And the national government had 17 of these commitments, amongst which is ending the maternal deaths, including ending obstetric fistula. This was a statement made by the former United Nations Secretary General Ban Ki-moon, who said that fistula has virtually been eliminated in most high and middle income countries and around the world. So even us, we can also do it in our country, Kenya. So what do you need to do? We need to increase or create awareness by educating our community. We need to expand the services where it is needed, more particularly even in the rural areas and even the low resource settings, including the informal settlements, where access is, many of the women and girls are disadvantaged. We need to improve the quality of care. And this is what, as we are working as UNFPA, we're supporting the ministry alongside other partners to do this. Last year, we did support the development of the MNH quality of care guidelines. And it's also training more clinicians, not only for fistula care, but also generally for emergency obstetric and newborn care and other healthcare workers in terms of supporting the maternal health. And also particularly, I mentioned that the midwives play a very key role in this. About 2 weeks ago, we did have the International Day of the Midwife, where we also advocate for empowering the midwives. Increasing the capacity of the health facilities, I think, in terms of just human resource, in terms of the equipment, the supplies, and even just the space. Some of the maternity wards are so congested. Advocacy and policy dialogue remains one of our key priorities. Of course, globally, we, as I mentioned in 2003, establishment of this campaign to end obstetric, to end fistula. Subsequently, we have been having every year the International Day to end obstetric fistula, and we're looking at also working on with advocating for gender empowerment, advocacy against harmful practices, and I've mentioned already the capacities. These are the priorities we are looking at: capacity strengthening, the quality of care improvement, community sensitization, resource mobilization, and partnership, because not any single partner can do it, but we do work towards ensuring that even the domestic resources, because some of you probably are aware, initially at maybe a decade ago, there may be relatively more partners working on fistula, but by and large, of course, there's issue of the prevention, but also the government coming into play in terms of availing the resources. And of course, we do acknowledge the Beyond Zero initiative on this in terms of mobilizing and also enhancing the partnership for management of fistula. Innovation and knowledge management that is trying to generate evidence what works best on this. In terms of financing, and I know Dr. Wala will talk much about it. She has worked along in some of the counties. Then was that having the UHC, as the scale-up process goes on, can this be specifically mentioned rather than just saying obstetric complications? And then other health insurance schemes, can they cover it reasonably? I know we have challenges which I know Dr. Kaliti may talk to in terms of the charges or what we're being paid for the fistula surgeons when they support the CAMS. And I like this story of, because even at old age, quality of life is still important. This old elderly lady was spotted by the president as one of the key things that lives in terms of transform, because this lady had lived with fistula for 50 years plus, but it's enabled her. When the repair was done, she comes from Kilifi. When the repair was done, she was able now, it brought so much joy and lived a new life. And in this case, she came even actually, this was State House. And the president actually acknowledged, and then I'd say decided to have a photo with her. Thank you very much, ladies and gentlemen. So I think we'll move on to our next phase. So you alert me when Dr. Kaliti joins. Dr. Mabea? Dr. Mabea, I can see he's online.
He needs to unmute himself.
Hello.
Hillary.
Yes.
Yes. Yes. Good afternoon once again.
Good afternoon. Good afternoon. I'm with Billy.
Yes.
Yes.
So you'll give us a brief introduction, and then maybe she can also speak to us how the journey has been in this with fistula, how it has changed. Of course, right now she is supporting the others who are undergoing treatment right now. Over to you, Dr. Mabea.
Thank you so much. I think the team knows me well. All my colleagues and team here. I hope you are staying safe. I'm wearing this because I'm keeping distance a little bit. So I'm so happy to be in this forum at this particular time. I hope you are getting me. Are you getting me?
Yes, we are. Go ahead.
Oh, okay, thank you. So I'm so happy that we have reached this time of ending fistula, International Day for Ending Fistula. And of course, we find ourselves in a very difficult times. But I think, again, These are times when we have no powers, and we have to do what's possible. So my name is Dr. Aaron Mabea, and I'm a fistula surgeon working in Care Women's and Fistula Hospital, and I stand a chance also of training other doctors in fistula surgery. Of course, we find ourselves in unprecedented times when we are caught up with COVID-19. Hence, we are now not able to operate maximum patients that we normally do, because our patients come from all over the country, hence there are some areas they cannot come. And of course, some are scared to come to hospitals at this particular time. But a few of the patients have come and demanded to be operated, and we have not had the chance to chase them away because they say that COVID is better than what they are suffering from. So there are patients who have walked in, and we are actually operating them at this particular time because of what they have suffered for many years. So today I have Miri Sosevwa, a young lady who suffered really severe obstructed labor, went to Kakamega Provincial Hospital, and she had obstructed labor. Her baby died. She suffered from intestinal ischemia. She lost a lot of intestine. She suffered from almost loss of the entire bladder. She also suffered from, as I said, a big part of the colon was damaged. I found her way back in 2014, and she has stayed with me for the entire period of time. She went through multiple operations, and finally she underwent urine diversion. Yeah, so she went through urine diversion, and she has stayed with us for the entire period of time. So I'd like to give her time so that she can actually speak a little bit about how her life was before the operation, during her many operations, and what is she doing at the moment, and what does she do to also help out in other survivors who are suffering out there. So maybe
Yes.
you can speak louder.
Okay, thank you.
Sure.
My name is Millicent Reseva. I come from Vihiga County, and I'm one of the fistula survivors. I got fistula when I was 27 years old. It was due to long, prolonged labor. I went to the hospital at Mount Teaching and Referral Hospital, where I had to undergo operation, and after that, I was operated, but unfortunately, the baby died. I was later discharged after 2 weeks. I went back home. After 3 to 4 days, I found myself just leaking without control. At that time, I was living with my aunt here in Eldoret. My aunt took me back to Moi Referral Hospital, where I was admitted again. I went back to the second surgery, where I found that the doctor told me I had a busted abdomen, where at first I didn't understand what busted abdomen was. But after a while, I later understood. I was taken back to the theater the second time, where I did my second surgery. After that, I was admitted to the ward 7 referral ward. And later, I stayed there for almost 1.5 months, whereby the doctors visited me every now and then, and finally, I met Dr. Hilary Mabea, who later gave me every support. He later transferred to Care Hospital, where he operated me everything, and now I'm okay. I'm now free from fistula, and I can do everything freely. I was later taken back to school because I had reached my Form 4 level. College level was not easy because my mother could not support. My mother had no business. At first I was staying with my mother after doing my Form 4. But here at Gynocare, Dr. Mabea and the rest of the staff supported me. I went back to college where I did my certificate level at Eldoret National Polytechnic and attained my pass level. I was later employed here at Gynocare Hospital as one of the staff members, and now I live happily. I can support myself and my mother. I thank Gynocare and the rest of the staff members for giving me this support up to this level, and I wish to continue for further studies. Thank you.
If you can ask a few questions. She's one of our favorite girls. She's actually my secretary at the moment. She's done social studies, and she wants to go back and do a diploma in social studies. And you can ask her a few questions and how her experience has been and what she looks at in the future.
Yes.
Okay, anyone having something, any of the panelists having something to ask?
Yes.
Habiba, you want to talk to her? I know you're familiar with her. Unmute. Mukiza, unmute. Habiba? Yes, Habiba,
I
go
don't
ahead.
have a specific question, but
Dr.
question for
Wala?
her. But I just want to take the opportunity to appreciate her courage to share with us her story and for everything she's doing to ensure that more women who have been through the condition are actually benefiting from the services.
Thank you. Yes, indeed, it's not an easy going through the many things that she has gone, the complications, or sometimes when as clinicians we talk about burst abdomen, we think that they know what it is, and we are speaking to ourselves, but it's not an easy one. And thanks a lot, Dr. Mabea, for the great work and even giving her opportunity to serve, because that is now integration, and even now just not only just even empowering, because even the high education that she's training, and you're saying that she's going back even for a diploma course in this to serve. So we thank you so much for the presentation. If should anything come, we'll be able to ask further. Do we move on to Dr. Wala, whom I had introduced, Elizabeth Wala, to share with us about, I know today we have given her something which probably, I don't know, I've not heard her speaking on human rights. But now she'll use whatever lens she wants to use. Dr. Wala, karibu.
Thank you. Thank you very much, Dr. Koro, and good afternoon to everyone. I work for AMREF Health Africa as a Program Director for Health System Strengthening. And AMREF, I think many people know it's more for the flying doctors services. So we are an international NGO. We are headquartered in Kenya, but we have presence in offices in around 7 countries in Africa and presence in around 33 countries. For us, ending obstetric fistula is top on our agenda in our advocacy work. One, because we believe that it is a state of human rights violation, because if you're looking at the statistics that are present, it's only happening in areas where women of lower socioeconomic status are found. So these are women who are not able to make a decision about their reproductive health choices. They're not able to access skilled delivery on time, and maybe the facilities where they go to access this skilled delivery is not up to par for one reason or another. So our approach as an organization in ending this is multi-pronged. And in terms of that, we look at it through a health systems lens. And this is where I will talk about different facets that we are approaching this. The first one is at community health level, and I know Habiba is going to talk a lot more about this, that we need to speak to the language that the community understands, where they're able to know why women and girls suffer from fistula, and most of it is preventable. So we are having communities where girls are getting married at a very young age. We are having communities where literacy levels for the girls is very low. So keeping a girl in school up to at least the 8th year of school, that's standard 8 in the Kenyan curriculum, has been shown to delay the first pregnancy. So education is a big component in this fight in the fight to end obstetric fistula. The other thing that we try to tackle at the community level is harmful community practices. For example, child marriages, female genital mutilation, which have indirectly been shown to affect this, because once a girl goes through FGM, then they are considered a woman and they're married off. And at that point in time, and I have the gynecologist here who will attest that the girl's body is not ready to deliver. And so many of them suffer from fistula. The other thing that we do is on the human resources side, which is looking at training of our health workers with the support of UNFPA and with the Ministry of Health and county governments. We have worked to develop a curriculum in training health workers on fistula prevention and management. And this was launched by our First Lady, Her Excellency Margaret Kenyatta, last year in May, in the last International Day for Ending Obstetric Fistula. So with these guidelines in place, our health workers are able to be trained and coached in line with prevention and management of the same. We have also, through the support of Global One and the fistula organizations, we've been able to train locally fistula surgeons, 2 of them through Dr. Mabea's highly specialized center in Eldoret. We have managed to get the support to train 2 surgeons who are from Garissa County. And so they've gone back and they're able to offer services right there at their facility, because we believe in providing care where the woman is able to access. Then the other thing that we are looking at, I think had been mentioned by Dr. Okoro, is on the money bit. So the health financing. One of the things that we are grateful for with this government is that the National Hospital Insurance Fund is currently reimbursing the cost of fistula surgeries. So we are encouraging as many of the communities as possible to enroll into the National Hospital Insurance Fund, because that will help to offset that. But in addition, we've worked with some of the county governments to pass legislation or policies and bills around ring fencing of funds that are meant for health. And we did this with West Pokot County, where we have an active fistula program. And we are happy to announce that West Pokot County is the first county in Kenya to pass a standalone bill that ring fences those monies. And this helps facilities to put in place measures and infrastructure that is required to support women to deliver safely. The other thing that we are working on is in terms of advocacy, where we have partnered with County First Ladies Association. We believe that they speak for women, that they're able to penetrate this. I want to single out especially the Bungoma County First Lady, Her Excellency Caroline Wangamati. Many of these First Ladies have spearheaded the voice of the voiceless. As we talked, we refer to fistula survivors as the voiceless, because many of them are shunned from the stigma that comes alongside it. So we are happy to collaborate with the county first ladies who are able to champion for this and pass on messages that are required towards ending obstetric fistula. The other thing that we are working on is on information systems. So one of the things that we've noticed is that fistula is not a condition that is currently identified and recorded in our health system, and that means that these women go unnoticed. They when decisions are made towards budgets, because fistula is not something that's reportable right now, it means that they are not accorded the rightful attention. So we have supported also the Ministry of Health towards revising of the documents that are in line with maternal care to ensure that all our health workers have attention to detail to any woman who comes after delivery to pick out if they have any issues after birth. Then the other thing that we have worked on is in terms of commodities, and this is especially with reference to getting these women to deliver safely at the county level. For example, in Garissa County, Marsabit County, Turkana County, we've supported the counties with mama kits. Mama kits are special delivery products that are given to mothers to encourage them to deliver in health facilities. They contain basic items that the baby uses after once they are born, and also for the mother. And this has served as an incentive for mothers to come from not to deliver at home, but to go to a facility. We've also supported the items like delivery beds and incubators, where the facilities are able to improve on the kind of service that they deliver. So looking at this, we are also partnering a lot with different sectors. For example, the private sector initiatives for fundraising and awareness, like we've done Fistula Golf tournaments, where we've reached out to the golfers to just spread the message, and also the contributions that are coming from the golf tournaments are taken through that. So we want to appreciate all the stakeholders. We work very closely with our specialists who are able to offer their services more or less for free, because they offer themselves for a whole week, where we go to a certain facility and ensure that women are receiving the services. UNFPA has been at the front line in supporting these initiatives, and we work with partners like Flying Doctors Society and Habiba's organization that reaches out to the community. So we need to put all stakeholders together on the table to ensure that at some point Kenya will have eradicated fistula. I think you've seen that the picture where Dr. Koro showed an old lady who's seated with the president. That woman has been surviving fistula for all the years that she was, around 40 years or more. We don't want our women to go through this. So thank you so much for this webinar, and I'm looking forward to the other interactions. Thank you.
Awesome. Thank you, Dr. Wala. We'll encourage our viewers, those who are listening, maybe to give their questions, comments via the Facebook, UNFPA, Kenya Facebook, and the Twitter account, and also from the panelists, using the Twitter handles for the panelists. I believe they are well known across. So our next presentation will be by Habiba. Yes, Habiba heads an organization called Wadadia, and also happens to be linked with the Fistula Foundation. Karibu, Habiba. Amen.
Thank you, Dr. Koro, and thank you, everyone. I really appreciate the opportunity to be here today. Yeah, as Dr. Koro has already introduced me, my name is Habiba Mohammed, and I'm the founder and lead director of Wadadia, but I also work with Fistula Foundation as the program director. For this purpose, I'm representing Fistula Foundation, and I'll give a little bit introduction about the foundation. Fistula Foundation is a non-profit organization that works in 32 countries across Africa and Asia. And just as the name says, the main focus is on fistula, and particularly the female genital fistula. In Kenya, Fistula Foundation started its operation in the year 2014. So April this year, we just marked our 6th anniversary of the program called Action on Fistula. The main goal for the Action on Fistula program in Kenya is to ensure there's an increase in access to care and treatment for the fistula survivors. And we are doing this through 3 different goals, or 3 different objectives. First, which is establishing a network of treatment centers. And currently, Fistula Foundation works with 7 facilities in the country, which are offering routine care services. So we believe that a woman doesn't need to stay for a long time, and an entire year or even 6 months is too long for a person to live with this kind of humiliation and the trauma that comes with having female genital fistula. So the second goal is strengthening outreach around the treatment networks, because we know one of the challenges we face is helping these women first to understand that they have a medical condition that is both preventable and treatable, and for them to accept to come out and access the treatment. So basically, rarely will you find a woman with fistula reaching out to you to get the services. We need always to reach out to them to be able to effectively support them. And that's why we are currently working with 5 partners who are community-based nonprofits or CBOs. And the 5 partners are actually operating in 19 counties in Kenya. And the effect of their work is felt across the entire country, because we have been able to treat clients in all the 47 counties of Kenya. The third core objective is actually training of fistula surgeons, because we understand without the competency the surgeons need to handle this kind of condition, we may not be able to do enough to support our women to get the kind of treatment they need. So since we started, actually Fistula Foundation partners with the FIGO, or to support Gynocare Fistula Treatment Women Hospital in Eldoret, to offer training of fistula surgeons. And since we started, we have been able to support 10 surgeons to access treatment at the Gynocare Fistula Center. So when you look at all our core objectives, they are converging towards ensuring that our women can be able to access the quality care they need to holistically heal from this devastating condition. And in the last 6 years, we have been actually able to support over 5,800 women to access free fistula treatment in different facilities, particularly the 7 facilities that we work in. And what we do, we provide transport to and from the facilities, and then we support the cost of surgeries in all of those facilities. And we support our team of outreach workers to ensure they can be able to go out to the community, to sensitize the community and identify these women. Yeah, now with this COVID-19, actually it presents a very challenging situation to all of us, like all the other partners who have spoken before me. Yeah. As we understand, fistula is supposed to be both a preventable and treatable condition. But what is the reality on the ground, and particularly during this pandemic? Are our women able to take measures that will ensure they prevent the occurrence of the fistula? And are they also able to get the treatment they need? I'll start by mentioning a little bit about the prevention part of it. We all understand that social and more so the physical isolation is at the core front of the fight against COVID. And this is globally, and in Kenya, it is the same here. So what that means is that to our program or to our intervention means is that we are not able to actually conduct or effectively conduct the community outreaches, which is an essential tool for ensuring the women or the entire community gets the message and understand that this is actually a preventable condition and the treatment is available and they can be able to access this treatment free of charge. So we are constrained because of the issue of the physical and and social isolation. Second thing, if you look at the kind of population we work with a very marginalized population with very low income. And at the moment, quite a number of our clients have lost their livelihood, and they're struggling even to put food on the table. So the requirement for them to have masks, and particularly masks in all the public places, is posing another challenge to our intervention. And this kind of challenge prevents these women from going out to even access these other essential services. Like you find the pregnant women will not be able to go to the facility to get ANC services because they don't have the masks and other resources that they need to be able to get there, like their transport and all the other factors, because the priority right now is being able to survive. And the key to survival is actually putting the food on the table. So you find that one is really affecting the issue of ANC services. And we know the outcome of pregnant mothers actually not attending ANC services when it comes to issue of fistula. There's also the issue of the fear of the unknown, anxiety about the COVID. And this is also actually impacting so much their ability to have skilled delivery, because a number of them are associating the facilities with the issues of COVID and the fear that if I go to any facility, I'll be tested, and if I'm found to have the condition, I'll be isolated there. Who is going to take care of my children back at home? I'll be required actually to pay for the quarantine or for the isolation at the facility, and I don't have even these resources. So you find that most of our women are actually ending up with home deliveries, which is going to be a key thing or a key factor in increasing the risk of them getting female genital fistula, and particularly the obstetric fistula. So you find this kind of challenges are actually coming on our way to prevention of fistula, because we are not able to give them the message, and they're also not able to access or make informed decisions that will ensure they prevent themselves from getting about the treatment. Is the treatment affected? Yes. Actually, the COVID-19 is affecting the treatment. Sorry about that. I'm just
Yes.
on silent.
Yeah,
most of our facilities are actually focusing on essential services, and fistula at the moment is really considered to be an elective surgery. So most facilities are not continuing with the fistula surgeries themselves. So we find like the women have to stay and have to wait with the condition for, we don't know how long this is going to take for them to be able to start getting the routine care services. However, I appreciate some of the facilities within our network which are continuing to be present and putting in place measures that women with fistula can be able to work there and still be able to access this kind of services. Okay. There's also something about because of the measures that have been put in place to contain the COVID, including measures around the transportation. So you find the cost of transport has significantly increased, and this really is affecting the women's ability to travel to different facilities that are willing to continue offering this elective surgery for them. So this is becoming another really burden. I know at Fistula Foundation, we are offering to pay the transport for them, which is an option. But in case then we are not able to get in touch with them, you'll find they're not able to really access these services because of the transport logistics. And that is really a major issue on our side. So looking at all these factors, we must say that the COVID is really seriously impacting on our ability to effectively support these women access the treatment that they require. Is there something that can be done to ensure that actually services are not disrupted, not just the fistula treatment services, but all the essential services at the facilities. Yeah, I believe our government is trying to do something and a lot is being done, but still more needs to be done and can be done to ensure we don't have to disrupt the essential services while we are fighting this COVID pandemic. Some of the key things we need to do, the first one is maybe to move the war of COVID to the community level, not just at the facility level, but really take it back to the community level and intensify it at the community level, because this is where we are having local transmissions, which is accounting for majority of the COVID Kenya cases within the country. And what can we do at the community level that is different, that we can talk about intensifying this war? First thing is actually creating a sense of community ownership to this project. As we can see what is happening in parts of the country, and I could say maybe what is happening at the coast, and particular section of the coast, where there's so much propaganda that is going on about the COVID, and people are not willing to go out to access the treatment because they have not really comprehended that this is a really issue. And even if there is an issue, there's something that can be done to help them in that. So I'm looking at a situation where our government needs to involve actually the key gatekeepers in this area to identify who are the people these people can relate with. Because in every community, there's a person the community are able to listen to. So when you bring something like, however right it is, however good it is, and you're bringing it more of imposing to them, the community are bound to resist because there's something they believe and they count on a certain number of people to share the right message to them. So for us to really be able to identify the key stakeholders, the key gatekeepers that the community listens to more often. And in some community, actually, we have people whose word is law, considered is law, irrespective of their status. So making them be part of this process, ensuring that they buy into this idea, they understand the nitty-gritties of the COVID, for them to be part of the process, because only them can be able to take the message and make the message be impressed within the community. So that will be really a key way of ensuring the community is involved and community gets a clear ownership of this project. We can also look at trying to empower the grassroots health workers. And I'm looking at the issue of like even the CHVs who are already working within the community strategies. And these people know all their specific household and they're working day to day with the household. You find most of them have already established a rapport or a relationship with the household that they work with. So if we could be able to empower them with the right knowledge and also to equip them with the right protective gears so that they can be able to go out there and be the supportive pillar to the fight against COVID, as well as the fight against the other issues we are dealing with in our case, like the FGF, because they can integrate the two messages when they are going out there. They pass this message because they're already dealing with the household level, and it is easier for them to be accepted because they've been working with this household for a long time and they have developed some level of trust. So they'll help us into that.
Yes, Habiba.
Yes.
Yes, I know you're passionate about what you're talking about. You're talking on, and I don't know, they will cut you short the next 1 or 2 minutes. You wrap up your.
Okay, yeah, okay, I'll wrap up. I'll try to be as quick as possible because I know, yeah, it is my passion,
so that
my very passionate area, and I can talk forever. So I'm looking at, we can also do something like maybe considering home-based care for the people who are affected, just to ensure we are decongesting the facilities and leaving them for essential services to continue, and also for the people who really need that kind of services. That will be really great. And refocusing our messages to handle the issue of the stigma, because there's so much stigma associated with the COVID right now, which is preventing people from accessing the care and treatment. And if that is happening, it's really affecting our other areas of the programs. And lastly, we can invest so much in our infrastructures, including the ICU, ventilators, and other things we know, without forgetting to invest in mental health. Actually, mental health is key during this particular moment, not to all the health service providers, to all the beneficiaries and the people of the community, because everybody is anxious right now. There's the fear of the unknown. We don't know what is going to happen next, and so many things are happening. So if you can be able to do this by ensuring we have hotlines where people can be able to call and have some sessions, psychological sessions, it will be a great way to ensuring we don't disrupt the services. Thank you.
All right, thank you so much. Biba, Ahmed, and Wadadia and Fistula Foundation combined in one. I think that's why you're very passionate about this. And lastly, we'll have Dr. Weston Kisa. He's also a renowned surgeon, and we have a few questions as you come in to talk to us about fistula. There's few questions here which you'll, as you talk to us and talk to the public, because you are live on Facebook and Twitter. People are asking, Emmanuel is asking, is fistula directly related to FGM? I know Habiba mentioned something to do with that, and there's a lot of discussions around FGM and fistula. And can it occur to any lady? And Jen is asking, Dr. Kisa?
Yes, I'm listening.
You're listening?
Yes,
and then what prevention measures can women, or can us as women, undertake to prevent fistula? Maybe you take those two, and then we'll also have Dr. Hilary Mabea talking to us about the other questions which are coming up. Keep the questions coming and your comments. Thank you. Dr. Kisa.
You want me to address the questions, right?
The questions, yes, and then also talk to us about some of the issues that have been raised, including how should the government health facilities, the counties, respond to the COVID, as well as prevention of fistula.
Yeah, you see, thanks so much. I must thank the panelists, because they have expressed what actually fistula is. I know many of us will want to know the exact definition, but I think it has come out through the presentations, and I don't think I should bother going into defining what a fistula is. Yeah, and I'll go ahead and say that in all these things that has been expressed, really a fistula is just a hole or a connection between the urinary bladder or the urinary system and the reproductive health tract of a woman. And like it has been mentioned, majority of these patients are actually as a result of labor and complicated labor. Now, the thing is, today, which you have already mentioned, our numbers are still high. It will be wrong for us to say we have seen the light. Okay, we have achieved something very important, what we call awareness, creating awareness in the community. And I'm so happy that like HAPIPA and African Medical Research Foundation, what they have done so far ever since we started managing fistulas in 1996, aggressively, I mean, in 1996 at the Kenyatta National Hospital. And I also want to mention that indeed, we have a challenge. The biggest challenge we have is that fistula still remains hidden. It still remains secret in the community. So even when Habiba goes to the community, it's not surprising that she may go to a community and come out of the community and still leave some fistula women or women living with fistula in that community. And this has been, to me, the biggest hindrance in terms of elimination or clearing the fistulas in Kenya. So the so-called secrecy, because the women are not able to gain confidence. The women have undergone what we call loss of confidence, social worth. And the women probably, because also of economic challenges, the women are not able to come out forth and fight for their right. as Dr. Wala said, this is also a human rights issue. The women are not coming out to fight for their rights. And
Dr. Weston,
yes, please.
Could you just put yourself on the video? People want to see who is speaking to us. Connect.
Okay.
Yes. Yes, thank you. Thank you.
Yeah. Yeah. Now, the thing is, we know very well from the studies that have been done that to be able to prevent fistula, you have to prevent women from getting pregnant, which is an impossibility. And contraception, for example, using contraception on a pregnant woman will not stop them from getting a fistula. We cannot tell from the women who are pregnant who come to see us in our clinics that this one is likely to experience obstructed labor. So for that reason, it becomes such a big challenge in terms of preventing fistula, even at the level of the government. And I think more importantly is that the government should come up with means or programs like what they have been trying to do, to try to improve the chances of these women attending an obstetric service while they are pregnant, in addition to preventing pregnancy or getting pregnant when they should or they are ready to get pregnant. And this is where contraceptive uptake becomes very useful. And if this is done and the women who are pregnant can access an adequate obstetric service, so that at this point, a prompt diagnosis when they're in labor, a prompt diagnosis of obstructed labor can be made and an action taken to prevent that woman from getting a fistula. Yeah, and if she doesn't, then eventually maybe she loses her baby, she gets a fistula, and she may also die. If this is done by improving access to emergency obstetric care by the government of Kenya, making obstetric service free does not improve utilization of the health facility. Much more so that this service must be respectful. If it's not, then the women shy away. And even if you remove the cost, maybe sometimes we should put in some cost. That's my feeling. That when people look at something which is free, they look at it with a kind of bias. Why is it so free? Why are we not paying something? So that a co-shared service provision might be a better way in trying to improve utilization of the women, utilization of the health facilities when the women are pregnant. And indeed, if you go back, if indeed it's a human rights thing, then the women are going, utilization of obstetric care is going to improve markedly if the women are educated. This education gives them a choice, gives them a voice. And therefore, if the government would really put in a lot of effort in education of women and the girl child, that will even reduce the chances of female genital mutilation and traditional practices, and improve utilization of contraceptive services, and in the process, improve the utilization of antenatal care, utilization of intrapartum care, and therefore prevention of fistula. We really do not wish to have to receive a woman who is leaking or has had an injury during childbirth. Like, for example, the case of the young girl, the story of the young girl who is part of the panelist who was presented earlier from Kainocare. I think that should be a major response by the government. This service actually should be given by the government. I really don't think the government should leave it to the NGOs, whether it's UNFPA or AMREF. AMREF and UNFPA and any other supporting organization should only come in to help improve what the government is already doing. Hello?
Yes, we are getting you.
Oh,
yes, so, okay.
That's all your questions.
All right. Sorry?
Have I answered all your questions?
Okay. Yes, thanks a lot. I think we've gotten the points. One, emphasis on family planning, the pregnancy. Preventing pregnancy is one key way of preventing the risk of fistula. I think we put it like currently the restriction of movement. There are very few vehicles on long distance traveling, and therefore even there's reduced traffic accidents. And therefore, similarly, when we bring this, the risk of the fistula, of getting fistula if you reduce the unwanted pregnancies or unintended pregnancies. And the issue of then access to emergency obstetric care. And even when we do access the maternity care, should be with respect, observing the rights of the woman. Dr. Hilary Mabea, good afternoon once again. Dr. Hilary yes, okay. Yes, someone is asking, how do you diagnose fistula? Just put it in a simple language that I can easily understand. How do you diagnose fistula? Can fistula heal by itself?
Okay.
And I know Lydian had asked, Lilian Kavilu had asked about the current restrictions and issues of the curfew. Are fistula cases increasing? I think this is, do we have any increase? Is because we see there's risk that some women are giving birth at home. What is the situation, right? So you have three things to address: diagnosis, are there increase in the fistula cases, and can fistula heal by itself, as asked by Emma Cheriot, asking whether must one seek medical attention. Over to you, Dr. Hilary.
Yeah, thank you so much for those questions. And I think I'll try to be as simple as possible. Dr. Kisa has actually talked about the definition, but in simple terms, fistula, how you diagnose that is through both clinical and examination. A patient has had a delivery through either normal delivery or a cesarean section. And then after some time, a few days, 3 days, 10 days, the patient starts seeing leakage of urine without any control, or swelling of stool without any control, if it's a rectovaginal fistula or a vesicovaginal fistula. So that's the first, the initial clinical presentation of a patient who has fistula. Post delivery, either normal delivery or cesarean section. A few days later or immediately after delivery or after cesarean section, the patient notes that she's not passing, but urine is leaking without control, or stool is coming out or is soiling without any control. That's what the patient sees. And then at the hospital level, patient walks in with that kind of presentation. The examination shows an opening on the bladder into the vagina, or an opening from the vagina into the rectum. So you can see urine coming out without any control, and it's just stool passing without any control from the vagina. These fistulas can heal on their own if they are small and tiny ones. Patient is taking a lot of liquids, water, and then other liquids. They can close on their own, or sometimes the doctor can put in a catheter for a period of 2 to 4 weeks, and small fistulas can actually heal on their own. But there are those ones which are bigger and persistent, and they cannot heal on their own until a surgical procedure is done to close that opening. That both for the rectovaginal and the vesicovaginal. Leakage of urine, stool, at the same time, surgery is required for maturity of those cases. What I've noticed with the restrictions of curfew now, at example, Gyno Hospital now, we do Linda Mama deliveries. We have actually seen an increment of patients coming for delivery, almost twofold. And we also noticed the case of prolonged labor also at the same time. I can't quantify the percentage, but mothers who are coming either in the morning because they could not come to the hospital at night have actually increased. So I've noted a lot of perineal tears during this period. And also I've noticed a lot of outcomes, poor fetal outcomes, because mothers have labored the whole night, and then when they get a chance in the morning to get to the hospital, they've had really prolonged labor. So I've seen this kind of upsurge in the last 2 months, where Gyno has recorded a huge number of deliveries that we never had before. And again, we have seen difficult perineal tears in the same period of time. So I suspect that after this crisis or this pandemic, those patients who are not able to come for fistula repairs will be there waiting, and they'll be coming. There'll be many. And then a new number of patients, I suspect, who ended up delivering at home. Because unless you have an ambulance or a taxi, some of these patients are not going to get out of the hospital, at home at night and get to the hospital for delivery. So we expect an upsurge of fistulas post-COVID, but we don't know the extent of that. Hi.
Thanks a lot, Dr. Mabea. I think key thing you mentioned, leaking of urine or stool is one of the commonest signs. But you also mentioned that small ones may heal on their own, but still needs to be seek medical care, because there's also a way in which that healing takes place. It's not just naturally as such, but there will be some care instructions which needs to be given. And important again is that there is increase in the number of the patients that you see at Gyno Hospital, as you have observed, but many of them having had prolonged labor, because from the clinical perspective, most of the patients who present in labor do present at night. And when with the curfew, that restriction is given. I know Dr. Wala will talk about Wheels for Life, how we can enhance referral during this season. However, unfortunately, there's the issue of the tears around the birth canal, or the perineal tears, and stillbirths that are being observed. So many of these will also be reported much later after the COVID. So there's an aftermath on this to know the actual magnitude of the problems that you see. So as Dr. Wala talks to us about Wheels, how do we enhance referral? I know there's the Wheels for Life in Nairobi County. I don't know whether there's any extended in other counties, and how can the counties work on this? Dr. Wala, health system strengthening.
Thank you very much, Dr. Okoro. I was looking for the flyer. So yes, I think as Dr. Mabea has mentioned, we are likely to see a surge in the number of fistula cases after we have gone through the coronavirus season. And that's because many women are actually not seeking care in facilities, especially during the curfew period or during the lockdown season. We need to encourage people to still get to a facility. And one of the things that we in AMREF, together with other partners, have started is an initiative called Wheels for Life. And we have started in Nairobi County. This was an initiative that was championed initially by a doctor called Dr. Jemima Karioki, who's a gynecologist obstetrician in training. And she used to give out her number and support women who needed to access facilities through her own resources. So we've partnered with Bolt, we've partnered with Rescue.co, we've partnered with Telesky, with PharmAccess, many other partners who have given of their resources, other than cash or kind, to enable women who are in labor during the curfew period to access facilities. So all a woman or a caregiver or anyone can dial 1196. I'll share the flyer later. That is a toll-free number. And this is the call center is able to direct these calls to doctors who are from the University of Nairobi and who are able to listen to what the woman is going through and give advice. And in an event where they need to seek care, they are able to call upon Bolt, which is a taxi company, or they're able to call upon an ambulance, all this for free, to enable the woman access a health facility during the curfew period. We hope to get more partners on board so that we are able to move to offer this service not just in Nairobi, but in other counties. I have noted that there are many counties that are also taking up individual initiatives to ensure that our women are able to get to a facility on time. So thank you so much, and I hope that we are able to get more partners on board so that our women do not suffer from fistula. Thank you.
Okay, thanks a lot, Dr. Wala, and we hope for the best. I know you have been discussing this. We're looking forward also how to strengthen the referral system. Sam Kitunga is asking which is the age bracket for more vulnerable with fistula. Who gets affected with fistula? Or whom do we see? I don't know whether Dr. Kisa, you can talk about that and tell us which parts of the country do we get to see many of the fistula and why?
Yeah.
Dr. Kisa.
Yeah. Yeah. And I think any woman can get a fistula, and much more so during the reproductive age group. When you do the assessment of or evaluate the women that have had fistula, you'll find that the majority of them are during the reproductive age group. That means between the age of 18, when many of them would probably be getting married or become sexually active, to the period of up to about 40 years of age. The majority of our women who have fistula lie in this period when they are actually expected to be the highly reproductive type of a woman in terms of their reproductive potential and history. And I must say that we try to come up with a map to show where fistulas are worst in the country. I know when we were growing up in medical school, we had areas that were associated with shortness of height. They were, and they were thought to be high in terms of fistula. But in places where we have high maternal mortality, in the country, they are likely to be the same places that are likely to experience a high instance of fistula. So if you were to look at the map and see which areas have high mortality, if you are looking at, let's say, Coast, then you find there are some areas in Coast Province that are associated with high mortality and therefore a high instance of fistula. If you were to look at in northeastern Kenya, then places where there is poor access, you can imagine while we were working at African Medical Research Foundation, we found women are much more easily reaching the health facility using a camel or a horse than using a car. So even if you gave them a 4-wheel drive, it will not reach them to the health center. So if you are using a camel or a horse, I mean, or a donkey, for example, you on average, a woman will take about 3 days before they have reached the hospital. If they are in labor and by the time they have made that decision to go to hospital, it's probably too late to save the baby and to save them from getting a fistula. Lucky if they are alive themselves. So this pattern seems to replicate everywhere, but I can't say that there's a community that is safe here in Kenya, even here in Nairobi, that are safe completely from getting a fistula. And if you are looking, for example, at perineal tears and rectovaginal fistulas, then it's avast everywhere. You only need to announce, and the women who have that problem of trying to control leakage of stool would be too many for you to handle. In our last 2 camps at the Kenyatta National Hospital, we saw them over, I mean, the numbers rising over even fistula women, probably twice. So that, and all of them, or majority of them, were from within Nairobi and the environs of Nairobi. So I wouldn't mention one community and say, this is the community that we should focus on. Ideally, all communities in Kenya have fistula and should be assisted.
Okay, so any woman who is at risk of getting pregnant can get fistula. We do know also, maybe Dr. Mubea will talk, as we come to getting closer to the end. I was expecting Dr. Kaliti is just told me he's joining again, but I have not seen him yet. Is that some of the cases that we see are what in the medical terms we call iatrogenic, probably inadvertently caused during the surgery for anything else, maybe not obstructed labor, but any other operation in the pelvic area. What's your take on this? I'll ask Dr. Mabea. Dr. Mabea is muted. Is it Mukisa?
Yes.
Are you, no, Mukisa.
Okay.
I want, there's Mukisa and Mukisa. I don't know that Kisa is a short form of Mukisa, but
not at all. But it's true, iatrogenic fistulas, or fistulas related to surgery, are getting more and more common. I believe we are doing more cesarean sections, or we are doing many more abdominal operations. So in my experience, the women I see in the women I'm seeing in private hospitals, these women indeed have followed surgery, either by hysterectomy and or cesarean section. And so we are seeing an increasing number of women who are coming following surgical related fistula. And also that the numbers, when the free maternity services came, and many women were coming for delivery in the hospitals. Again, at that point, there was a surge of iatrogenic fistulas. So iatrogenic fistulas are going to be with us as we continue to increase our services, obstetric services. It is just that it calls upon the universities to improve their capacity in terms of training of the obstetricians and the gynecologists in performing cesarean sections and gynecological operations. That way, we are able to reduce the incidence. At the same time, that we urge the surgeons to be very keen, especially in terms of detecting injury, either to the ureter or injury to the bladder during cesarean section or pelvic or abdominal operations. When this is done, then they can call somebody to come and assist, or a surgeon to come and help in trying to repair the bladder or repair the ureter, so that we kind of prevent the woman going through the stress of leakage of urine after surgery. That's not enough. Also, we're seeing a very increasing number of radiation or malignant fistulas too, so that women are coming to us because they have advanced cancer of the cervix, of the vagina, of the bladder, yeah, and or following radiation. So, and we are not so trained well in managing women who have radiation or cancer fistulas, so that we also urge that the government and many stakeholders to improve screening for cancer of the cervix or gynecological cancers, so that we reduce the number of radiation and malignant fistulas.
All right. Thank you so much. I think we are getting to a close. And I would request us to maybe one or two statements as we come to a close, your message to the government and whoever else. How can we end fistula within this generation? Do I start with Habiba? I think yes, you've kept her quiet for some time. Habiba? Yes.
Yeah, thank you. I think so much still needs to be done to ensure we can be able to end fistula across the world. And the major thing that we need to focus on is to be able to institutionalize the services and look at them from a comprehensive level. When the women with fistula should be able to access fistula services in any of the county or even sub-county facilities at an affordable or no cost at all. And then the fistula also needs to be looked at from a comprehensive perspective, not just from the physical part of it, but also from the social, from the economic, and from the mental health perspective, so that all the dynamics are addressed comprehensively.
All right, thank you. Yes, Dr. Mabea.
Yes, thank you so much. I think I also want to go.
And to give our friend also when you finish so that she can also say a word.
Okay, great.
Yes.
I just want to say that I want to echo Abiba's comments that the government, apart from having brought in the mama as a way of getting mothers to hospital, they should make it possible for these mamas to get a quick, accessible, and safe cesarean sections in those facilities, so that we can actually reduce prolonged obstructed labor. The government should not just leave only the NGO world to take care of our 6 cents. So the government has a responsibility to take care of its people. Because when a patient has had a fistula, I think it's a very unfortunate thing to happen. So the government has a responsibility to come in, support the NGO world, and save its citizens from this kind of disease, which should not be there at this particular time. The other thing is that Dr. Pisa talked about iatrogenic. I think we really need to teach our residents more techniques of cesarean sections, because some of the cases you see is obviously from our own doctors who have caused the fistula. We need to train more of our doctors, give them more techniques of prevention of fistula. Some of them is not that we don't have the doctors are there, but they actually cause actual damage to the ureters, they cause actual damage to the bladder. We need to train our doctors more on cesarean sections. We should not assume that a cesarean section is simple. So we should just teach our young ones who are now becoming doctors on good techniques. Finally, I think if I give, I want to say that post-COVID, we need to put in systems. We pray that the COVID does not stay here for long. The moment it comes out, we go back to helping our mothers and our healthcare system. COVID has taught us a lot of things in terms of how we can innovate and do better. So I hope that at the end of this COVID, we do better in terms of getting our mothers operated, the ones who are suffering, and then do a lot of community work to our women so they can get to hospital and get a safe delivery and live babies. So maybe I give Siba to say something.
Okay, thank you. Mine is just to thank the Dynacare and the rest of other doctors for supporting us to fight this fistula. Thank you.
Okay.
The sound is faint.
Get her? Hello?
Hello, we are getting you. She finished. Millicent has.
Okay, thank you. Mine is just to say thank you to Dana and the rest of other doctors who have excellent.
Okay. We appreciate your sharing the story and wish you well as you also continue serving the community. Dr. Awala.
Yeah, thank you very much for this session. I think just to emphasize that as we are trying to flatten the curve, that other services need to still continue so that our women are delivering safely in facilities. So let us ensure that there's a way of continuing care, even as we are trying to enforce some of these measures in order to flatten the curve. And thank you very much for having me on the webinar.
Hello. Internet is unstable. Hello. Hello.
We can hear you.
Yes. 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 Sorry, there was a small power outage here, and then now it's switching off from the modem, from Wi-Fi to modem. I think that disruption. Yes. Thanks a lot, Dr. Wala. Yeah, we also appreciate your contribution. Dr. Kisa.
Yes, mine is to say I cannot overemphasize what the panelists have said in terms of looking forward to eliminating fistula amongst us. I want to say also that we should look what Habiba said, mental health, because mental health is so crucial in these women, even after a fistula has been closed. I've always asked myself this question, that why would the government support women to have free delivery and not support them, the same women, if they have been injured or they get injured during the process of delivery? I've never understood. And so I still call upon the government, because it is their duty to really serve the women, to make sure that the women go to school, to make sure that they live a healthy life, there is enough food, there is a transport, and the hospitals are well equipped in capacity to help the women who go there, whether in labor or they have a fistula. Thank you so much.
Thanks a lot, a call for all of us. And I can see the graduation from just closing the hole to even looking at the mental health of these women, because previously people concentrated on the whole, then they went to the other physical well-being. Now we are graduating even to the mental well-being. So the holistic approach, even in terms of the treatment. So it's not just a leakage, there's leakage, yes, but also there's leakage in the psychological status of these women. Thank you so much. There's someone who has been on the background here. Stina, you have not heard her voice. They may not be having fistula in their country. Stina.
They do.
She works with us, and she's from Denmark. Stina. Mukisa.
Yeah.
Or Mukisa is also off.
No, I'm still alive.
Okay, no, yeah, you know, now when I may say Mukisa, I should say Mwenesi.
Okay. I think like my name.
All right, thanks a lot, everyone, for your participation. Those who have been viewing, those who have been following us on Facebook and even on Twitter, and for the panelists who have shared with us their experiences, have educated us. We very much appreciate, on behalf of UNFPA, the Minister of Health, who was presented by Dr. Kaliti, who was not been able to join us even last minute. Then, and for the fistula community and for the women and girls at whom we serve, we work towards preventing them getting fistula. I think prevention still remains the key thing, as much as we want to mop up the backlog. Thank you so much. Wish you all the best as we celebrate. Continue passing the message, continue serving the women and girls. Thank you so much. End gender inequality, end health inequities, and end fistula now. Thank you so much.
Okay, bye.
Bye. Asante sana. Yes. Mokwasi, I cannot even see because I've been my screen has been muted, so I was Mukisas.
I'm so sorry.
All right, thanks a lot.
You're welcome.
Thank
So
you.
yes,
Thank
so
you. Nothing.
okay. So tomorrow we'll see whether we can do something small in Narok, and then when things ease